Okay.
Dr. Keith Smeagol, how you doing?
Doing awesome.
Great to have you here. So,
Thanks for having
yeah, you're most welcome. So what I wanted to do is just I'll briefly introduce you a little bit in terms of background, then maybe you can introduce yourself and your pretty unique practice. So what's interesting about you as a practitioner is you kind of span, you're an integrative kind of practitioner. You span the medical field. You're doing interventional stuff. You're doing regenerative medicine. And you're doing physical rehabilitation, and you're an Fnor practitioner. So you're kind of integrating Fnor in a unique way, which I thought was kind of cutting edge and very current. And I thought for practitioners out there that are into regenerative and or physical rehab, you would be an interesting person to talk to. So perhaps you could introduce yourself in terms of your practice and let people know what you're all about.
Okay. So my name is Dr. Keith Smeagol. I'm a chiropractor. I'm also a family nurse practitioner. I have an office that's called Regen Pain and Wellness. And what that office involves is functional rehab. It's got a chiropractic facility. It's also a regenerative medicine facility. So it's a multi-therapeutic approach to pain management. That's basically what this office is about.
So what sort of procedures are you offering? Because I think, if you correct me if I'm wrong, is you've moved very much away from the, if I can call it, the old school orthopedic procedures, the corticosteroid injection and basic physical rehabilitation and kind of, holding back the tired kind of interventions in joints, and you actually kind of got into the regenerative stuff, the new wave. Perhaps you can talk about some of those.
So what I established here was a system that a patient can be put through, not only to get them out of pain, but also help regenerate some of the tissues that they have lost through the change in biomechanics they may have had through the years. So with these regenerative medicine model, we can do that now. It's here in the United States, and we're allowed to practice that way. So that's how this office is functioning today in present time. We're actually helping patients get out of pain, but also it's kind of like the fountain of youth, man. We're getting their joints to heal and to remodel and rebuild.
Yeah, so I think people are kind of, the regenerative kind of wave is kind of out there, like a lot of people getting into it. But maybe if we can go through some of the type of therapies that you're offering. So one of them is PRP that people may have heard of. Could you kind of describe what PRP is a little bit?
So PRP has been around for quite some time, and there's actually some papers that are very promising on PRP for patients with osteoarthritis of the knee. So PRP is, we take a blood draw anywhere from 30 to 120 mLs of blood, and we put it through a process, and that process involves just taking the platelets out of that concentration of blood and then re-inject them into the area of the body that has a damaged tissue. So it's an autologous process, meaning that we get the PRP from you, from the actual patient, and we take that substance and we inject it into the site that has either a torn tendon, a torn piece of cartilage, some muscle degeneration, and also it helps new tissues develop and grow.
Yeah, actually, I popped some ligaments around my ankle several months ago and had PRP. It was fantastic. It was remarkable.
Yeah.
Have you found that there's that kind of more people are turning up asking for these procedures, or is it still kind of an uphill getting people to know about it?
Some people are aware of it. They're kind of confused by it because there's a lot of different biological injections available today. And the buzzword in today's market for regenerative medicine is stem cells. So I don't even use stem cells. The reason being is because it's kind of misleading, the advertising for stem cell therapy. Because a lot of these practices are using solutions that they say they're stem cells, but there's no live cells in them. So basically, and that's been a big problem with regenerative medicine. So stem cells is a great procedure. It's very expensive, but I think a lot of the public's being misguided. So I make sure when patients come in, they understand, that PRP is not a stem cell, but we have other biologic solutions that have a lot of growth factors in there. And I can go over those with you.
So you're talking like exosomes?
Exosomes, amniotic fluid. So yeah, there is a hierarchy to these regenerative therapies. And, PRP works great, but it's one of the most cost-effective procedure that has a lot of growth factors, but some patients need more. Some patients need more growth factors. And basically, what happens with PRP is when I take a PRP or blood draw from a patient that's 45 years old, those growth factors are 45 years old. But now, I have available, and a lot of these regenerative medicine clinics have these exosomes that are available, and they're 0 day old. So they are much more viable, vibrant growth factors that we can actually use along PRP. So we use PRP with the exosomes.
And what are there limitations to the exosomes, like in terms of regions of the body that you would or wouldn't use them?
No, because the fascinating thing about these exosomes is when you have osteoarthritis of a joint, and that joint is chronically inflamed, you have these enzymes in the joint that continually break down the joint. And what they figured out is that these stem cells that they supposedly were injecting years ago, and they still are today, they thought that these stem cells would proliferate into specific tissues. So for example, if you had broken down meniscus, you would inject these stem cells, and they thought that these stem cells would proliferate into a piece of cartilage. What really was happening, through nanotechnology, they discovered that the stem cells weren't proliferating into these new tissues. They were actually creating a cellular signal through these exosomes. So now they figured out a way to extract these exosomes off these mesenchymal stem cells. So it's another step they use in the stem cell processes. We take these stem cells, and then we take the exosomes off those stem cells. So now we have those exosomes available to utilize in this practice.
Yeah, I think things have definitely come a long way since the corticosteroid injections, and I think people are kind of just moving away from those. Even when I speak to patients these days, especially active people that are kind of doing research on the internet and whatnot, they don't want those steroid injections anymore. They're looking for alternatives. Absolutely. Yeah. So you're kind of integrating them now. People are kind of, I know that people may have heard of these. It's very likely that people looking at this video would have heard of regenerative therapies. Some of them are actually implementing them in their clinics and practices. But the question that I have for you is, right, why is it that you feel the need, if these regenerative therapies, where you can regenerate structures in and around the joints, if they're that effective, and certainly that sound like they are, and you're having great results, but yeah, why then would you need physical rehabilitation? Why would you need physical therapy if these are great?
Physical therapy is fantastic. Regenerative medicine is fantastic. Chiropractic is fantastic. But what I figured out is a combination or multiple therapies in one visit is life-changing for patients. Basically, we live in an accelerated pace in today's society. Patients don't have the time to make multiple visits to an office. So basically, if I integrate FNOR with the regenerative medicine, the results are fast and they're long-lasting. Basically, if they had faulty biomechanics originally, and I give them this wonderful regenerative medicine injection that they spent a lot of money out of pocket because insurance doesn't pay for, we want to make sure this lasts and lasts them a lifetime. So if we incorporate a pre and post rehabilitation program, that will happen as long as the patient can remove that provocative movement that was upsetting that joint and helping that, creating that joint to break down. We can integrate rehab along with these regenerative procedures. It just makes these dynamic changes for these patients. And the main thing is that it happens fast.
So Keith, you're pretty experienced in kind of in various schools of therapy, and you don't have to list those, but I personally know the kind of things that you've done in the past. You've done a wide range. I mean, I don't think there's anything you haven't done in physical therapy. Why is it that you ended up settling on FNOR? Why was it this particular approach to rehab that you ended up settling on?
Okay, so FNOR, it's the analysis. It's like finding where the pain driver is coming from, and the analysis of FNOR is very specific. And when doing regenerative medicine, if you can have an area that you're working with very specifically, you can help that patient very rapidly. So the FNOR model gives me the tools so I can find the faulty biomechanics, integrate a rehab protocol, and then, of course, if necessary, integrate some of the regenerative medicine models that I use in this practice.
So have you found in any way that it helps to direct some of your interventions with respect to regenerative therapies?
Absolutely. So with regenerative medicine, we can do nerve injections, we could do an actual joint injection, we can do a tendon injection. So yes, with the FNOR model, we can help determine which tissue we're going to inject, because again, when you're doing these regenerative injection procedures, they are expensive. Patients are paying out of pocket. They're expecting results. That's the bottom line. So if I can determine exactly what the problem is and resolve that, it, you know, makes the office, me look good, and the patient's happy, everybody's happy. So that's the model that I choose to practice.
Okay. Well, thank you. So, I mean, look, I mean, that's kind of how we've kind of found it, is that the way forward is definitely integration. There's so many interwoven factors that are feeding into any one pain kind of case, that it helps to, first of all, prioritize, because it's like you're not dealing with this flat wave of, you know, all these different variables, you know, with the same weighting, but you kind of it's important to develop a system to kind of triage. You know, get doing your highest leverage interventions first, and then, you know, the cleanup afterwards, and the ability to move between, you know, different domains, whether it's a metabolic chemical intervention, or whether it's an intervention that is biomechanical in nature, or you know, or even behavioral for that matter. But Keith, you said you had a couple of cases that you wanted to just briefly show us, to kind of show how you might integrate the physical rehab aspects, specifically around the Fnor, with some of your regenerative interventions.
Yeah, and as some of you may know, with Fnor model, we look at gait. Gait analysis is crucial for any pain sufferer, especially low back and knee pain. So this is a triathlon that came into the practice, and I'll show you this little video. I don't know if you can see it on the screen here.
It's pretty cool.
So you can see he has a lot of hip rotation, that left hip.
Yeah, so keeping it kind of in basic terms we can understand is that, you know, and obviously when we're doing analysis, we're kind of actually measuring things and going a little bit finer detail. But, you know, you and I can definitely see as trained eyes what's going on with that pelvis. But the idea being that in the normal gait cycle, when you're traveling from one leg to another, there should be nice fluid, you know, mechanics around the pelvis. If not, it's kind of like a waiter trying to balance all these things on a tray where the foundation is unstable, and those things on the tray being kind of likened to the spine, and we end up stressing the structures of the spine. And so what you're looking at over here is, you said, a triathlete or Ironman?
Yeah, triathlon, highly competitive triathlete. Had low back pain, knee pain.
And how long had this person had knee pain and low back pain?
You know, it was getting worse and worse as he was training, and basically he gave up training. He was dropping out of a triathlon, and then came into the practice. We did the analysis. He had quite a few different issues going on, because he had a lot of knee pain, a lot of low back pain. But basically in about 5 or 6 weeks, he actually performed in that race, and he didn't win the race, but he did really well. He was happy. So,
well, so if you don't mind me, so if you don't mind me pointing out at this stage, is that one of the things that we kind of emphasize in the system is that, you know, that's a perfect case, because in many cases it's the same factors that are causing knee pain as the factors that are causing low back pain, and these are not, you know, separate problems. Is that when you look at global biomechanics, particularly that foundation of normal gait, like if gait's not normal, nothing is normal. And you know, you can't build normal movement on poor gait. That's the most basic of bipedal, you know, standing on 2 feet is called bipedal stance or bipedal gait, and walking is the most basic of those. And if the walking cycle, the gait cycle, is abnormal, nothing is normal on top of that. So you know, when we used to have this experience of, you know, somebody comes in fact, I've worked in orthopedic practices where they go, okay, you got knee pain, you got a spine complaint, and you got an ankle complaint. Which one do you want us to deal with? Like, literally, right. You have to put these orthopedic complaints in order so that you could treat one at a time. When in fact, that approach is flawed from the beginning, because what's actually going on in most cases is that these are all related. They're related to the same global movement problem, and they're related. Anyway, let's have you talk about what did you end up doing for that particular case?
So after the gait analysis, we review the gait with the patient, and it started making sense to him. It's like, you know, average person walks, you know, 6,000 to 10,000 steps a day. You know, he's probably, you know, with running and training, he's probably doing 35,000, 40,000 steps. I'm like, so every time you're walking or running, you're upsetting these joints in your back and your knee. So with him, we started the rehab process. We did Fnor rehab with him. I started applying some topical prolotherapy with him. It's called Prologel, and you get fantastic results with that. But I also did some PRP injections on his facet joints to help stabilize his low back, because his low back has been a problem for a long period of time. So he did really well utilizing the Fnor and some regenerative medicine models.
So when you're using Prologel, do you use it? I assume if you follow the model, you're applying it diagnostically and therapeutically, right? So how?
Absolutely, and they're kind of blown away because they think there's lidocaine or something in there. It's kind of numbing them out. And I show them there's nothing in here that's numbing, and so it is a diagnostic, but also therapeutic. And a lot of times I'll just use the Prologel with patients, and sometimes I don't even get to do my regenerative medicine. We talk about it on an initial visit, but sometimes, you know, a lot of the cases with the rehab and the Prologel, the patients do fine, and then they could save the money on you know, the regenerative therapy, the injection therapy we were going to perform.
So if I have you right, what you're kind of describing is an approach where you're looking at the faulty biomechanics and understanding that if the faulty biomechanics is there, it doesn't really matter what your particular joint problem is that you have to attack that biomechanics, because whatever biomechanical problem brought you into the intervention, you're going to have it when you walk out, even if the joint is being restored and you can regenerate a number of those tissues. Those same forces are going to keep degenerating the tissue. So
I'll be back in the office eventually.
Right. So that's the approach, is to essentially fix the biomechanics, get the pain done as fast as possible, and restore the joint, and hopefully this is a long-term benefit, right?
Yeah, absolutely. And the best thing about Fnor too is, you know, patients can spend a few dollars after we have them come into the office, and they can continue doing the rehab at home.
Yeah.
You know, after they learn the model and find out, you know, this is my problem, and that's what we encourage the patients to do.
Okay.
And the other thing too is, like you mentioned, patients come in and they say they have low back pain, knee pain, ankle pain. You know, which one do you want to treat first? I know that if we can address the biomechanics, that a lot of these other issues are going to clear up. So the patient, you know, wants all that fixed. So they know that I know that once we correct the instability, the provocative movement, the patients, their other problems most likely will correct themselves.
Excellent. So how many cases of post-surgical pain are you seeing where people have gone and had the fusions and the different surgeries and ended up and this combination of interventions has helped?
So I just had a patient today. He had 3 low back surgeries. He's got hardware in his lumbar spine, and he's just really failing. He's not doing well. He can't work. And, you know, the problem is he doesn't have a lot of financial resources. So we start off with the Fnor protocol. We start doing some rehab with him, get him able to walk, getting him able to get in and out of the car, take care of him, self-care. Yeah, those cases are challenging, but we do get great results with those types of patients, because sometimes, you know, after the surgery can go beautifully. Everything went perfect, but the patient's still in pain. And I see quite a bit of that. And then we discover that some of these nerves in their low back, they were never really treated properly. They're never treated at all. So what we do is we do some neural prolotherapy on them, where we go and either do a topical or injection on those nerves, and all of a sudden their pain that they've had for a long period of time has disappeared.
Yeah. So do you have any other cases to show us of any other videos there?
Yeah, we had another case, a patient with knee pain, and I'll pull it up here in a second.
So this proves that this is a spontaneous live thing right here. Okay. So this is somebody that came in was there
instability.
Yeah. Was there any structural problems with the knee on X-ray or MRI?
You know, she did have a torn meniscus on the left knee, but the MRI was like 2 years old, and it wasn't really bothering her until about a couple of weeks ago. And then she came in here, and we did a gait analysis, and this is what we uncovered. And I have some more views. We have a sagittal view, we have a posterior view, and go through those.
So the idea is you're looking at biomechanics in different planes. So not only a combination of how they're walking, but as you look at that looks like a relatively simple task that somebody would be doing every day, right? You know, stepping down off a step or.
So again, a lot of left hip rotation.
Oh yeah, you can see very big problems on that left hip.
Go back again. So even though we're filming her low back, this is not a low back case. This is a knee patient.
Yeah. Yeah. So the idea being, and you can see very significant left hip problems over there, and obviously you measure that. So I'm assuming that on that particular case, when you did the actual measurements, there was a significant problem there.
Right. So we would take that video, put it in software, and then we had different angle measurements we'd see on there, and very precise. And actually show the patient, and you show them where the dysfunction is.
Great.
Absolutely.
Well, Keith, as we kind of wrap it up, thanks. I mean, this is a nice brief conversation. Obviously, you're kind of one of the advisors for the Fnor project. We very much appreciate your input. Just as a little introduction, it's nice to hear people talking about how it can be integrated. But I guess if you could say one thing to the rehab specialists that are out there, that's number one. Kind of what being that you've gone and got current with a lot of things. You got current with kind of injection therapies and interventional therapies and the medical side, and you also become current on the rehab side. What would you say to rehab specialists that are out there? And then what would you say to people that are looking to get into the regenerative space? What would you say to these people?
Okay. Yeah. So the first thing is it makes practice extremely exciting again. Because case by case, it's very individualized. Typically, years ago when a patient came in, you kind of already know what you're going to do before the patient walked through the door. Now it's very specific, and you get right to the root of the problem and laser beam focus. That's the main thing, and it's really exciting because you really light up patients' lives quickly. And that's the thing is they walk out of the office, they know something's happening, and they're excited about it. So that's the main thing that I really enjoy, how the Fnor model integrates with my regenerative medicine practice. The other thing too is people looking to get into regenerative medicine. Yes, it is getting more and more popular. There are a lot of outfits out there that hold conferences, and some of these conferences actually have a didactic component and also a practical component. So they actually bring cadavers in where you can practice on. Those are the courses that I would look for. And if you want specific names, I don't know if I could provide them here, but I can do it through email or somebody. You can give them my contact information, and they can contact me, and I can provide that information for them.
Well, Keith, why don't you give people your contact information if they patients or physicians, if they'd like to get hold of you? Why don't you give them your website or your contact details?
So my office is in Scottsdale, Arizona. The name of the clinic is called Regen Pain and Wellness, and that's the website, regenpainandwellness.com. 602-485-9390 is my phone number. You can get it that way.
That's brave. You just gave it. Well, Keith, I want to thank you so much for your time. This is a nice introduction. I think what we can do is have you on in the future and have you. Let's dive deep. Let's dive deep into some of these therapies. And let's let people know kind of what's out there. And I know you're a wealth of knowledge, and appreciate you keeping it very superficial for a wider audience, introductory. But as I said, I think if people show an interest in the regenerative therapies, perhaps we can have you on and let's really dive deep on it.
No, I enjoyed this. Absolutely. Exciting times in healthcare.
I think so. All right. Thank you very much, Keith. We'll have you on soon. Thanks.